Thank you very much for inviting me to chair that session. So the idea was to talk about, the NPM1 DNMT3A co-mutated AML patient and how we should treat a respective patient cohort in the future based on some new data that have been emerging and which we are also going to present at this year's ASH meeting. And this perhaps would be also one of my favorite ASH contributions, which I'm going to mention to AML Hub. Induction and post-remission treatment strategies for a fit newly diagnosed patient with NPM1 DNMT3A co-mutant AML. I think you're all much better aware than I that the clinical relevance of DNMT3A mutations were controversially discussed for many years, and depending on the clinical trials you looked at, the data were quite different. So I wanted to give a brief overview of where we stand today, and then we can jump into the discussion. So you already mentioned the new WHO classification. I think there nothing has really changed. AML with NPM1 mutation is still a genetically defined AML subgroup, but additional co-mutations are not really taken further into account, and the same accounts for the new ICC, where the NPM1 mutant ones are also buried in this cohort, AML with recurrent genetic abnormalities. But on the other hand, we all know that I think the one thing I also marked mutated NPM1 without FLT3-ITD in red up here. So in the ELN, the updated ELN risk classification, NPM1 mutant ones are found in two different categories. If they come along with a FLT3-ITD, then they are going into the intermediate risk. So what has changed here is that the ratio is not taken into account anymore. So if a FLT3-ITD is present, it's rated intermediate. Only NPM1 without FLT3-ITD is favorable. But for many years, looking at the cohort in more detail, we know that AML is a subgroup that is, of course, also not only heterogeneous on the molecular level, but that these gene-gene interactions, the co-mutational patterns also impact outcome. And here we looked in more detail in data that we had published together with Peter Campbell's group long time back, where we had looked at 1,500 AML cases. And out of these, 435 had NPM1 mutations. We could identify co-mutational patterns that were linked to especially these aberrations, DNMT3A, TET2, IDH, that drive the epigenetic code that are frequently linked to clonal hematopoiesis. And we know that if we find mutations in older patients, they might mean something different than in youngers, as we know that the biology of the disease is changing. Many more of these have a previous history of MDS, and therefore it's not surprising that they also, of course, might impact outcome. Then we also looked at the co-mutational patterns with regard to clinical outcome in more detail in that study. And here on the bottom, I'm not sure whether you can see my mouse, on the bottom you can clearly see that the NPM1 FLT3-ITD cases, which we now would already consider intermediate prognosis, if they come along with a DNMT3A mutation, they are by far worst with regard to patients really staying into complete remission after first initial therapy. Many of them relapse and die later of the disease. So this is by far the worst cohort, even though with regard to the initial chance of getting patients into the CR, it's not too bad. And when we did some initial outcome analysis together with Moritz Gastum on that data, you also can see here that the NPM1 DNMT3A FLT3-ITD mutant cohort is really doing poorly. The ones that only have NPM1 and DNMT3A alone, this is here the dark blue cohort, they are nearly doing as well as the NPM1 cases without additional co-mutations. So it looks like this cohort, if FLT3 and DNMT3A are coming together with NPM1, that is a really poor prognostic outcome. And what we have now done was of course obvious when we put together more data in the Harmony Alliance project to of course also look at these co-mutational patterns for the NPM1 mutant leukemias. So we have now over 1,000 cases in Harmony, which we could put into the analysis. They were all intensively treated, that is the younger fit patients. And this is data that is also going to be presented at ASH by an oral presentation by Alberto Hernandez. And what we have done then, of course, used machine learning algorithms and heuristic search algorithms to look at the data to identify gene-gene interactions that would impact outcome in NPM1 mutant AML. Here you see the characteristics of the cohort. That's a normal cohort, which you would expect for NPM1 mutant cases. At the median age here was 53, younger than the median age in AML. But nevertheless, there were also older patients in the cohort. And with regard to the ELN risk classification, most of them, of course, were favorable intermediate. Couple of P53 mutant cases in there. And then what were the most frequent NPM1 co-mutations? Again, DNMT3A, FLT3 as expected from other studies. And now you can see how the analysis looked like when you take additional co-mutation patterns into account. You can further substratify AML patients with NPM1 mutations in different outcome groups. And the most important finding here was that, again, if the NPM1 mutant cases that are P53 wild type, if they have a P53 mutation, they all do not very well. If they come with a FLT3 IDD and have an additional DNMT3A mutation, then they are definitely also not running well and should be considered an adverse outcome group. And multivariate analysis confirmed the model. And when we looked at additional data that was recently published, again by Eli Papamanuel's group, so this is data coming from Britain, you also can see that cohort, here's the red line, the FLT3 mutant, NPM mutant, DNMT3A mutant do really poorly. And the question is now how we should move forward. Of course, the data shows that you can reclassify cases. Of course, this is all retrospective analysis, doesn't really take into account the new compounds which we have at hand. So definitely needs to be validated in further studies. But I think we all know that this is a high-risk cohort, and this is now going to be discussed. And in the last couple of minutes, only, or 2 minutes, I think. And on the other hand, I mean, the question would, of course, also be whether we could use MRD to further guide our decision in these patients. So you all know that MRD is also a valuable marker for NPM1 mutant AML. But on the other hand, this is an example that also shows you that the difference is quite huge, that NPM1 can go down quickly, DNMT3A, the clonal hematopoiesis can stay up, and patients can relapse during despite staying negative, that the persistence of the clonal hematopoiesis and the previous chemotherapy has the power to select additional clones that then can lead to a therapy-related AML. But nevertheless, I think if a patient gets quickly MRD negative, we know that their risk of relapsing is also lower, and that together with the gene-gene interactions, I think might better help us in the future how to determine or to determine who should be transplanted and who not. And I'm looking forward to the discussion. Okay, shall I ask a question, a specific question, or perhaps everyone can raise the hand? How, if you would have a young patient with a FLT3 positive DNMT3A positive disease, would you move forward to allogeneic transplant for consolidation therapy? If yes, please raise your hand. So we have one hand, only one hand. So why would the others not transplant the patients? I would also move forward to a transplant if possible. So Uwe, why would you not transplant a patient with FLT3-ITD and DNMT3A mutation?
Well, not raising my hand doesn't mean I wouldn't transplant. I thought we would discuss it. Well, of course we would go for that. I mean, that's basically common sense and also part of the guidelines. Yeah.
Okay. So the raising hand did obviously not work that well. Yeah. So no, I think is this. Yeah, everyone is agreeing with that would be common sense. So my question, of course, also would be, would we need additional data to prove that this is the case, especially in the light of the new compounds such as kinase inhibitors? Before, or should we then also like include the information in then like I mean, the new ELN guidelines just came out. The question is whether we should already think of a new update. I mean, I guess Hartmut Döhner would not be too happy with that if we would hear me put that question out. What do the others think of data like that? Gunnar, how would you move forward in the future?
Well, we would look for NPM1 MRD and not necessarily transplant patients in MRD negativity. But that's of course in relation to other aspects as well, age and comorbidity and things like that.
So, like the presence of a FLT3-ITD in addition to a DNMT3A, and given the data I just showed, you would nevertheless say, okay, if he's MRD negative, the risk of relapse is lower, and we have a high chance to get him in a second CR, then you would still only transplant in second CR. But would you keep the patient on a FLT3 inhibitor maintenance therapy then?
With the FLT3-ITD, we would transplant if possible. So,
okay.
So I was referring to DNMT3A.
Or DNMT3 alone, yeah. So yeah, I'm definitely, perhaps I should have put the question. So I was always talking about the triple mutation, which is the bad one. Yeah. DNMT3A alone with NPM1, we also would not transplant. We would rather follow up the MRD, and then, if they are negative, definitely no transplant. And if they are still positive, of course, that's, you can then discuss whether you should move forward to transplant, or you would rather give a maintenance with oral azacitidine, which would be an option in that case, right? But we definitely then would perhaps rather move forward to a transplant if they stay MRD positive for NPM1 mutation.
Yeah, Lars, maybe I can add something. Gert, even if it's a FLT3 negative positive patient and it's really MRD negative by molecular NPM1 assessing, then we would also not transplant those patients. We would continue with midostaurin in the maintenance. We would follow up with MRD assessments every 2 months, and in case of a rise, then we should transplant, but not on forehand.
And you would do then MRD for NPM1, but not for FLT3 and DNMT3A?
No, just for NPM1.
Is anyone doing MRD for FLT3 at the moment, or this is still only experimental? Because recently there has been interesting data published in Blood on the value of MRD monitoring for FLT3 mutation using NGS technology, but I think it's not routinely used yet. But is anyone also doing it in an experimental setting? What would be the common thoughts here of the group, that Do you agree that the presence of DNMT3A mutation in these NPM1 mutant leukemias might indicate a different biology, because it might be linked to clonal hematopoiesis, more older patients, or would you only be afraid if it's one of these, if they have co-mutations that are clearly linked to MDS? Agnieszka, perhaps would you consider a FLT3 NPM1 mutant person with DNMT3A worse than without DNMT3A? And would that impact your treatment decision?
So, you know, in the light of this harmony data, I should consider it as a higher risk AML with the higher risk of the relapse. So I think it should be verified prospectively.
Mm-hmm.
So probably I would consider the close monitoring of MRD and the transplant only in the situation when MRD is rising, or the conversion of MRD negative status. And coming back to your previous question, so we are starting the experimental use of FLT3 for the MRD monitoring right now in the current the PCR group. So we would like to have our own experience and also to see if it's manageable to replicate the nice results published this year.
Mm-hmm. Yeah, thanks. Yeah, because I think in the future, I mean, if we would monitor all the markers we have available in the patient and can do that accurately, I think we will definitely gain information, because it also can happen that the NPM1 mutant subclone is staying low, and a FLT3 subclone, a different FLT3 ITD clone might come up. You know, we have seen this in our analysis in the past, and I think that also, of course, might help to better then guide also maintenance therapy under kinase inhibitor therapy. But so my feeling is now, so with regard to NPM1 plus FLT3 ITD considered intermediate risk, for many of you, the decision to move forward to transplant would depend on whether they really get MRD negative and how the patient is doing. So not everyone would move forward with a FLT3 ITD mutant, NPM1 mutant patient to transplant right away, right? So that's a little bit...
And of course, it's important issues to consider the transplant-related mortality and the risk, transplant risk. So just to balance the benefits and also risk of transplantation in this subset of patients.
Anyone else? Some additional thoughts? So we would conclude that it looks like DNMT3A is only adding unfavorable prognostic outcome if it comes together with FLT3 ITD. I think there the data is quite solid, but nevertheless, all of that is still based on retrospective analyses. Even though it can be confirmed in independent data set, we should do prospective testing of that. And if it is confirmed in prospective clinical trials, then it might have the power to be entered into an upcoming update of the risk stratification. Is this good summary?
Yes, I think so, Lars, and I'm already convinced based on the retrospective data that it is a prognostic bad category. I think there are a lot of data now available apart from the harmony data, but I think nevertheless, if you look to the data on the Ivy paper on the value of the NPM1 MRD monitoring, it says that it was completely dependent of all other co-mutations. So it nevertheless, even if it's a bad prognostic category, you could still argue that you could rely on MRD concerning your transplant indication.
Yeah, that's a good point, because then the idea would be despite the fact that you have the high risk genotype, but nevertheless become MRD negative, that would also indicate the chemosensitive good bad ones, if you wish, and in those you also would not need the transplant necessarily, right?
Yeah.
Okay, good. Okay, this is all I had. Thanks for the discussion, and then I think we can move forward to the next point.